All right, let's dive right in. We're going to walk through a really high-yield clinical examination for knee soft tissue injuries. The goal here is to break down the key maneuvers you absolutely need to master for a confident diagnosis. So let's get to it.
So you've got a patient who comes in with an acute knee injury. Now what? That's the big question, right? In this explainer, we're going to build a super clear, systematic pathway for your examination. We'll cover all the essential steps and the special tests you're going to need in your toolkit. Okay, so where do we start? Well, the very first clinical sign we're looking for is effusion. That's just a way of saying there's fluid building up in the joint. Now, a swollen knee is a pretty obvious clue, but we need specific tests to actually confirm it. And that brings us to our very first maneuver.
So the ballottement patella, the key here, and I mean the real key, is the tactile feedback. It's what you feel with your hands. You're not just pushing down on the kneecap. Nope, you're feeling for a very distinct tap as the patella hits the femur and then bounces right back up. That dancing patella sensation, that's your money sign. It's a definitive indicator of some serious fluid in that joint.
All right, so we've checked for fluid. What's next?
The logical next step is to test for instability. This is where we really start to evaluate the integrity of the ligaments. We're going to be checking for both side-to-side stability, that's your collateral ligaments, and front-to-back stability, which is your anterior-posterior stuff.
So you can basically break down all of ligament testing into two main planes. First up, you've got collateral stability. This is all about assessing the medial and lateral integrity, and we do that with stress tests. Then you've got anterior-posterior stability. For this, we use some really specific maneuvers to see how the cruciate ligaments are holding up.
Now, with the stress test, the direction of your force is literally everything. You've got to stabilize the thigh, then apply a really directed force to the lower leg. A valgus stress, that's pushing the knee inward, medially, that specifically challenges the MCL. A Varus stress, pushing it outward, laterally, that isolates the LCL. And in both of these, what you're feeling for is any excessive gapping or, well, looseness compared to the good knee. That comparison is crucial.
The drawer test. This one's a classic for a reason. You've got the knee bent at 90 degrees, and you're directly testing for that front-to-back movement. If you get an excessive forward pull, that's a positive anterior drawer, and you should be thinking ACL injury. On the flip side, if you get too much of a push backward, that suggests a PCL tear. It's a super direct way to spot a potential cruciate ligament rupture.
So why is the Lachmann test so darn effective? It all comes down to the angle of flexion. We're only at about 15 degrees here. By doing that, you basically minimize the blocking effect you can get from the menisci and even from the patient tensing their hamstrings. It seems like a subtle change, but trust me, it makes this test way more sensitive and reliable for an ACL tear than the drawer test, especially when you're dealing with a painful, acute injury.
And listen, if there's one thing you remember for your exams and for your actual clinical practice, it's this. In an acute, painful, swollen knee, the Lachmann test is your most dependable, your most reliable clinical tool for diagnosing an ACL tear. Period. Master this test, and I guarantee you'll catch injuries that other people might miss.
Okay, let's talk about the pivot shift test. Now, this one has a very specific use case. You are not going to use this on an acutely injured knee because, wow, it can be really painful. But for a patient with chronic instability, the one who tells you their knee just gives way all the time, this test is perfect. It literally reproduces that giving way sensation, that subluxation event, and confirms that functional instability from a bad ACL.
Okay, so we've checked the ligaments. Our systematic exam now moves on to the meniscus. These are the knee's critical little shock absorbers, right? And for these, we're going to use some specific provocative tests. Basically, tests designed to poke the bear and elicit the signs of a meniscal tear.
So the McMurray, the Payre, and the Steinmann tests. These three are pretty much the core of your meniscal exam. And look, they each have a slightly different approach. One uses dynamic motion, another uses bodyweight compression, another uses isolated rotation, but they all have the exact same goal: to stress or trap or compress a potential meniscal tear and see if you can provoke that telltale click or that sharp pain.
So, here's a common problem. How do you tell the difference between a ligament injury and a meniscus injury when the pain is right there on the joint line and the symptoms kind of overlap? It can be tricky. But thankfully, the Apley test it's elegantly designed for exactly this purpose.
The beauty of the Apley test is that it's all about one thing: compression versus distraction. So, with the patient lying on their stomach, you first apply axial compression. You're pushing down while rotating the tibia. If that causes pain, you're likely grinding the meniscus, so you're thinking meniscal tear. Then you do the opposite. You switch to axial distraction, pulling up on the leg while rotating. If that causes pain, you're not grinding the meniscus anymore, you're stressing the ligaments. It's such an effective way to isolate exactly where that pain is coming from.
Whew, okay. We have covered a lot of ground. So let's boil all of this down to the most critical, high-yield points, the stuff you can take and apply directly in your clinical practice tomorrow.
Okay, here are your takeaways. First, always be systematic. Fluid first, then ligaments, then menisci. Got it? Second, that positive Ballottement test is a cardinal sign of a big joint effusion. Don't forget it. Third, for an acute ACL tear, Lachmann is your go-to, most reliable test. For a chronic ACL, the pivot shift is more suitable. And finally, when you're stuck between a meniscus and a ligament injury, use the Apley test to differentiate. Pain on pressure means meniscus, pain on distraction means ligament. Seriously, mastering this pathway is absolutely essential. So I'll leave you with this thought. What other joints in the body could you apply this same kind of systematic approach to?